Alrighty guys, so I will be lecturing on esophageal varices today. I absolutely love talking about varices with my clinical students. I have one really good story about it. It's not something that you see super commonly. I had a patient that was in for alcohol withdrawals in DTs, and I'm sure that most of y'all know alcohol is one of the few things that you can detox on that will actually kill you. It'll sneak up on you and get you. So we were taking care of a patient going through DTs, and he had a severe seizure, and shortly after began vomiting gallons of blood. He did end up coding, and we sent him to the CCU where he did pass. He was very young, so this condition is something that goes very unnoticed until it's almost too late in a lot of people. All right, so to begin, we'll start out by just diagnosing esophageal varices. So these kind of varices are dilated, tortuous veins that are usually found in the submucosa of the lower esophagus, but they might develop, bless you, they might develop in the higher in the esophagus or extend lower into the stomach. Varices are varicosities that develop from elevated portal pressure. That's the veins that drain into the portal system. These varicosities are very prone to rupturing and are often the cause of massive hemorrhages from the upper GI tract and the rectum. Once they form, they will only increase in size over time and have an increased risk of bleeding with clot abnormalities that are commonly seen in patients with severe liver disease, as Ms. Grimes already covered. The overall mortality rate for variceal rupture is about 10 to 40%, and that's related to failure to control the bleeding once they begin hemorrhaging and the reoccurrence of bleeding once it's fixed or resolved. And this, of course, is a picture of some pretty significant esophageal varices. So going over how these are formed, we talked about the portal vein system. The obstruction of the portal venous circulation is caused by scarred or damaged liver tissue, like we see in cirrhosis, that leads to venous blood from the intestines and spleen trying to seek an outlet. And that's where we get into the concept of collateral circulation. I'm sure that you guys have heard about collateral circulation in the area of the cardiac world. When there's a blockage in the heart that's not resolved, the body fixes itself by growing new vessels to accommodate that blood flow. That can also happen in the portal system. So the new pathways, of course, we're calling that collateral circulation. This causes increasing pressure, especially in the blood vessels of the submucosal layer of the lower esophagus and the upper stomach. The collateral vessels are not elastic like normal veins. They call it tortuous and fragile. So like we saw in this picture on the last slide, you see they're not really nice and straight and even, like some of the veins that we see on veiny people, they're really curly and twisted looking, very bulging. So we call that tortuous and fragile, meaning that they will bleed very easily. These kind of varicosities have fatal outcomes related to hemorrhagic shock. So if your patient starts hemorrhaging, they're going to be experiencing lowered cerebral, hepatic, and renal perfusion. They're going to have increased nitrogen levels from all the blood that they're getting into their GI tract, and of course high ammonia levels from their already present liver disease, and this increases their risk of developing encephalopathy. That's going to increase their confusion and agitation, which we'll talk about momentarily. So, who is at risk? First, we'll talk about the development of esophageal varices, and then we'll go over who's at risk for rupturing their varices. So, like we said before, the number one cause of development for esophageal varices is portal hypertension. That can be developed by the severe liver scarring seen in cirrhosis. It can also be caused by the presence of blood clots or thromboses, parasitic infections, specifically of schistosomiasis. I'm not sure if you guys remember talking about that in your micro class or not. It is a parasite that attacks the livers in humans specifically. Or most commonly, like we discussed earlier, continued alcohol use. Some of the less common causes that you see in younger patients may include anatomical abnormalities in the splenic circulation, or of the vena cava. So, discussion question number 1. What might cause you guys to have a little bit of hesitance in assessing your patient's history of alcohol use? What might make you a little bit nervous to ask them how much are they drinking? Do what?
You don't want to insult.
Right. They are easily offended. They are very self-protective of their habits. If you ask them how much, they'll probably tell you, oh, I just have a couple of beers here and there. But it's imperative. I don't want you to scare your patients, but if they're in a critical condition like that, sometimes they do need a more firm icebreaker. Like if you're really not going to be honest with me, you could be in more danger to yourself than you know. We have resources that are available to help us in asking appropriate questions to these patients. Does anyone know those questionnaires we can use? The what? Right, we use CWA scoring to help us rate their detoxing from alcohol. What about screening questions for their history? Right, so there's 2 different questionnaires. There's the CAGE questionnaire and the TASTE questionnaire. Ask them if they've ever considered cutting down on their alcohol drinking. Do they feel annoyed when people bring it up with them? Do they ever feel guilty about their alcohol consumption? Or ask if they often require an eye opener. So if they get up in the morning, they're not feeling great, they take a shot to feel a little bit better, that is an eye opener. And then the TASTE questionnaire is pretty similar. You're going to ask how many drinks does it take them to feel the effects or to feel high from the drinking. Again, ask if they feel annoyed by people bringing up the subject with them, if they've ever considered cutting down, or again, if they need any of the eye opener drinks first thing in the morning. So, talking about who's at risk for rupture, these patients have internal esophageal varices that are well established. The kind of hemorrhages and bleeding that we see are often seen in patients that have done things requiring a lot of muscular exertion, like lifting heavy objects. So they might be straining for a bowel movement, sneezing, coughing, vomiting. Patients who have esophagitis or a lot of inflammation and irritation of their esophagus, if they don't chew their food thoroughly or drink really irritating fluids or super spicy foods, like they're just drinking orange juice all day, every day, they're eating Takis, hot sauce, stuff like that. And gastric reflux, especially in patients that continue to drink alcohol. If your patient also is taking medications that erode their mucosa, such as salicylates, everybody that you have is on aspirin. So they're going to look through that medication list on admission, and they're going to take that out of there real quick. Usually they'll be taken off their blood thinners at that point, so we'd probably see them on SCDs or TED-HOs by the time we get them. All right, so why do you guys think that activities that are related to muscle straining put these patients at increased risk for rupture? Why is that? Right, it increases the pressure. So straining, like really just bearing down to have a bowel movement, severe coughing fits, or like we see very commonly vomiting fits, it puts so much more pressure on the blood vessel system and the portal system. It jacks up that hypertension, and it can blow in a way that we don't want it to. Alrighty, so the signs and symptoms of this, you will never see esophageal varices with your naked eye unless you're doing an autopsy or something. The only way that you'll see it in a living patient will be via endoscopy. So like we said, these are large bulging veins. They're tortuous and fragile and are not elastic. So if your patient has external varices, I'm not sure if have we already done the picture that has the external ones? So they're like big, bulgy on the outside of their bellies. If they have them on the outside, you can already assume that they have them in the inside already, and they are well established by that point. So you'll most likely see these patients after their bleeding has already started or when they're hemorrhaging. So we're going to watch them for hematemesis, which means perfect. Who can tell me the difference between melena and hematochezia? Yes.
Melena is black tarry stools. Hematochezia is passage of fresh blood via the venous, usually in or with stools.
Perfect. For those that couldn't hear, the melena is dark black tarry stools, and the hematochezia, bright red frank blood passed through the rectum, usually in large volumes, very ugly to see. So in these patients that are hemorrhaging, you're probably going to see an acute change in mental status, acute confusion, very sudden weakness, and of course those shock symptoms, cool, clammy skin, very low blood pressure, and skyrocketing heart rate. Alrighty, so to diagnose these patients,
Can they not feel it? Like these aren't painful?
no, they will not feel it. You'll have no idea that it's happening until it's going to start coming out of one end or the other if they're hemorrhaging. Now, if they're bleeding like a slow, continuous bleed, you'll probably start seeing it in the bowel movements. They might come into the ER and say, my bowel movements have started turning really black and sticky, or I was throwing up a little bit and I saw a little bit of blood in my vomit. That's usually how they'll present to the ER if they're more stable. If they're not so, they'll probably start throwing up massive amounts of blood at home, and then they'll come to the ER. Yeah, very not painful at all for them until it's a little bit too late. So the number one diagnostic test for this condition is an immediate endoscopy. We need to go in there and identify the site of bleeding and identify that cause and make sure that it is a ruptured or bleeding esophageal varices. At this time, it's imperative to watch them for early cardiac arrhythmias, further perforation, or if they're not hemorrhaging currently, they may start to hemorrhage or may hemorrhage during the procedure. If in the procedure they identify a current bleed in the endoscopy, the patient will be placed on an NPO status immediately. The physicians may also choose to use ultrasound, CT scans, or angiography to evaluate the bleeding. We could also measure the patient's portal hypertension by using a balloon catheter into the portal venous system. On the lab work, these patients are already having a lot of liver issues, so we can expect to see increased liver function tests like the AST and ALTs. We may also see increased bilirubin and increased serum protein. If they're bleeding, absolutely we're going to check that H&H and make sure that we are on stable grounds for that.
Can I ask you a question?
Yes.
Okay, so before we talked about like you'd see major decreases in protein, so I didn't know why it was that all of a sudden the protein would be increased. Because the other in the lab it said decreased albumin, decreased protein, and then this one says increased protein, and I just didn't know.
I think what you're referring to is when Ms. Grimes was talking about the long-term severe liver disease like cirrhosis. The increased serum protein would be more in an acute process, like the rupture. So that increased blood going into the GI tract, the body does have to break that down, unfortunately, which causes that increased serum protein level as well as the increased nitrate level that we talked about before.
Okay, awesome. Sorry, I just wanted to make sure I had that.
No, you're good. All right. So beginning with our treatment, we're going to start with medical management. For these patients, we can definitely anticipate they'll be getting large volumes of IV fluid replacement, probably some electrolyte replacement, magnesium, sodium, and potassium, absolutely. They will probably be getting blood products or some alternatives if they are Jehovah's Witness. What kind of alternative volume expanders might we give someone that is a Jehovah's Witness that doesn't take blood products? Right, albumin. Do what?
Would they donate to themselves the autologous transfusions?
Do they do that?
Mm-hmm.
Yeah.
Yeah.
She said autologous
Yeah.
transfusions, self-transfusions, absolutely. So we are going to be monitoring their INOs very strictly. We might place a Foley catheter just to keep a very close eye on that. They might be, if they're NPO, they possibly could have an NG tube with low intermittent suction just to make sure that there's no more irritation on that gastric lining. We need to make sure that we're using extreme caution with the fluid hydration that will start. If we overhydrate our patient, we can cause increase in the portal pressure, which will cause our bleeding to get worse and start back up again, unfortunately. In the pharmacological world, we want to start some vasoactive drugs. They need to be given ASAP, and especially before they go to endoscopy. So the first option we might choose is octreotide. It's also called sandostatin. This is going to help decrease our bleeding from the varices without the vasoconstrictive action seen in vasopressin. So if we give this medication, we're going to watch our patient for low blood sugar because it can cause increased GI motility, a lot of cramping there. So watch them for dropping in blood sugar. Abdominal cramping is definitely a common complaint with that medication. This kind of medicine you'll see on a drip. It's also given to patients with bleeding gastric ulcers. I've seen that a lot. If we do choose to give vasopressin or pitressin, that will give us some constriction of the veins. That's going to decrease the portal pressure, which is perfect for urgent situations. We do have to use it with caution because it does have antidiuretic effects, and it does increase their risk of dysrhythmias and extremity ischemia with the increased constriction. Beta blocker medications such as propranolol or nadolol and nitrates, those medications are used as preventative treatment for patients that already have established esophageal varices. That's going to help keep their portal hypertension on the lower side and decrease their risk for either rupture or rebleeding. All right, so we're in an emergency situation. Our patient comes in the ER, they're vomiting massive amounts of blood. What are we going to do first to stabilize them? We are going to use the balloon tamponade. This is for temporary hemorrhage stabilization. It is an emergency control method for massive hemorrhage. There is an extremely high risk for tube displacement, especially with life-threatening airway obstruction. This is where our very confused and agitated encephalitis patients come in. Because there is such a high risk for tube displacement that could cause airway obstruction, they also have risk for balloon rupture or aspiration of blood and secretions. We can help to mitigate some of those complications by intubating the patient beforehand to protect the airway, which of course requires some level of sedation to keep them calm while on a vent. These patients you may see, unfortunately, in restraints. If they are extremely confused and agitated, they're going to be pulling and jerking at anything that they can get their hands on, which unknowingly to them will put them in extreme danger for obstruction and strangulation. So remember that when we use this balloon tamponade, it's only supposed to be temporary. We're stabilizing them so that they can go and have a procedure to stop their bleeding, and then we're going to get it out of there as soon as we can. So if it is left in too long, we're putting that patient at an increased risk for developing ulcers and necrosis within that esophageal lining. So after we get our patient stabilized in the ER with our balloon tamponade, we're going to send them to either of these two procedures. They could go for endoscopic sclerotherapy. They're going to go in endoscopically and inject the area around that bleed with a sclerosing agent. Basically what that does is fries the tissue around it and creates a scar, blocks off that bleeding. The other option is endoscopic variceal ligation or banding therapy. They're going to go in and put a small rubber band or metal clip over that bulging vein that's bleeding. We like this option much better than sclerotherapy. It has a way lower risk of rebleeding, less mortality, and much less complications associated with it. They could also go in and do the TIPS procedure, which I believe Shannon's going to be talking about later on in the lecture. Different surgical options, most commonly seen if it's severe or they have very advanced esophageal varices. They're going to be having a bypass procedure or surgical decompression with shunt placement. They're going to be put on the transplant list because they need a new liver bad. We also could see them do devascularization, where they're just going to go in and they'll seal up that whole vein that's tortuous and distended, so we decrease that risk of rebleeding and hemorrhage again. Or they could do a staple gun transection. It's kind of like folding those veins up over itself and stapling it to compress them so no blood's going through there any further. All right, so our pictures here. The top left is our sclerotherapy. So they're going to be going in with this endoscopy with this needle tip, injecting the sclerotherapy the sclerotherapy injection to cause like the frying of the tissue and that scar formation. The top right, it looks like they've used some metal clips to kind of band those bleeding varices. And the bottom one is a balloon tamponade tube. Of course, it's not inserted, but they've got it blown up here, and that would go either nasotracheal or orotracheal down to their esophagus, where they would then inflate it, and they're going to surgery immediately. Of course, the balloon tamponade, again, is only used for emergent hemorrhage situations. You might see a variation of this used. I'm not sure if they've learned about the nosebleed part yet this semester. So, okay. So, okay, yeah. So I've never seen this, but they do sometimes in emergency hemorrhage situations in the nasal area. They'll use this for tamponade for like extreme nosebleeds, stuff like that. All right. So now it's our patient, and we got to take care of them. We're going to be doing frequent vital signs. These patients with the emergent hemorrhages will probably be up in the CCU for a little bit. They're going to be getting continuous vital signs, frequent neuro checks. We're going to be watching their neuro status. Of course, if they have an NG tube with suction, we may need parenteral nutrition at some point. Of course, if they're active bleeding, we're going to be watching that NG tube output. We can anticipate these patients to be started on vitamin K therapy because of their severe liver issues. They're already going to be at a very high risk for bleeding, so that vitamin K replacement is going to help build up their clotting ability. Or they could have alternative products. If they're getting blood products, they could get alternative options like for the Jehovah's Witnesses. We're going to make sure that we're creating as calm of an environment as we can. We want to minimize their anxiety and agitation, especially if they're very confused. Let's ensure that we're establishing excellent communication with our patients and their families. Sometimes patients with intubation can be on conscious sedation. They're going to be scared, of course, because they're not going to be able to talk to you. Or maybe if they are on sedation, you can still talk to your patients, right? Kind of ensure them that they're safe and that they're being taken care of and that we're in a good environment. And especially with their families, if they come in and see Uncle Richard tied down to the bed with all sorts of tubes down his throat, they're probably going to freak out a little bit and want him untied and not intubated anymore immediately. So we'll need to make sure that we're establishing a good line of communication with our families and get them in on the loop of our treatment process. Especially if our patient is withdrawing from alcohol use or going through DTs, we're going to be performing that CWAS scoring someone mentioned earlier, frequent CWAS scoring up to every 2 hours as needed. For our non-surgical patients, we're going to be reassessing medication effectiveness, make sure that our octreotide drip or vasopressin drips are working. Watch for rebleeding, a reoccurrence of that, especially if they've gone for that sclerotherapy or banding surgery. Maybe infection if they've done an open shunt placement. If they are intubated, of course, we're going to provide oral hygiene, continually reassess for confusion and agitation. If your patient starts pulling, we might need to restrain them to keep them safe. All right, so last question I've got for you guys. If you have a patient with balloon tamponade or intubation that is confused and at risk for pulling out lines, how are you going to communicate that to the family member in an appropriate manner so that they know kindly what's going on?
Just that I already mentioned that we take is to keep the patient safe, so that we need to have restraints on them or possibly even sedation if they are intubated.
Absolutely. Make sure that we put our patient safety as our number one concern. If that family member comes to us freaking out and want us to untie them at that moment, we can definitely emphasize to them that we are only acting on that patient's behalf to keep them safe from choking themselves to death or aspirating on blood or other secretions. Absolutely, great answer. All right, guys, these are the references I used for my presentation. If you'll notice, I used mainly your textbook, so it's a great study source. All right, does anyone have any questions before I hand it over to Ms. Grimes? No? All right. I do have a quiz handout that goes along with this lecture. We'll do it kind of towards the end. It's not for a grade.
We can pass it out now.
No?
I think Ms. Kraft is in the classroom. I text her.
Here.
You're there? Okay, yeah. I think
Okay,
we
so
knock
we'll
it
go
out
ahead
real
and do
quick.
it. It's not for a grade, unless you guys really want some extra credit or something. I wouldn't mind giving it to you at all. So do your best. I'll be grading them, but it's not for a grade for you guys. All right, thank you guys.